and welcome to the latest ECIST podcast. We're talking today about embracing risk. My name is Ben Owens. I'm an ED consultant at Sherwood Forest. I'm an ECIST associate. And with me today is Bharath, who is a community geriatrician. But you can introduce yourself, Bharath.
Hi, thanks, Ben. I'm Bharath Lakkappa, a consultant in geriatrics medicine, and also I'm the clinical director in adult services in Northamptonshire Healthcare Foundation Trust, and also a clinical associate with ECIST.
So tell me how when you see a patient in the community, you decide, a sort of frail older person, how you decide whether they need admission, whether they need monitoring. How do you make that assessment of the risk for the patient?
I think the biggest thing about embracing risk, Ben, is keeping it simple. So we've got parameters, which is the clinical observations, and we got the clinical intuition of staff. So we do get referrals from primary care, ambulance service, patient themselves, or it could be other clinicians and sometimes social care as well. At that time, a senior review happens, and they follow the same principles as most probably you've heard of the National Early Warning Scores, National Early Warning Score 2. So the criteria for admission when we review somebody is if somebody is unresponsive. It's obvious barn door entry to hospital, but we use the other principles. A score of more than 3 in one parameter or a 6 in total. And we also look at how the patient is. So if the patient doesn't have dementia, or they're looking like they're confused, or they're looking with hypoactive delirium or really quiet compared to the normal time. And then if they have dementia, we take that into consideration to say that if there's infection or something happening to them. The other thing which we use is for a chest infection, we've got a certain useful scores we can use, like the CURB 65 score, and if they're more than 2, then we consider them. If they're 3, obviously that the mortality rate in the next 30 days is 22%, so we do admit them. But recently we have seen patients refusing to be admitted. We have not done an audit of that. If they do become unwell, they do go in. Might be later, but because the patient has a choice and the capacity is done, they stay at home. The second aspect is we've done the assessment, and then we keep it really, really simple. We look at, first of all, as the activities of daily living. Are they able to maintain themselves, or could we help them with the family members or with support of the health and social care team to keep them at home? Are they able to get the meals and the medications on time and in appropriate manner, whether a carer is at home? We usually ask help from the neighbors, family, friends, but right now in COVID, that's much, much harder. Unless it's a bubble, we then have to consider that, which it is a bit of an issue, but otherwise no. The third aspect is we tried in COVID time to minimize interference in the patients because of staff. Even though they tested lateral flow tested twice a week, hopefully most of our staff, nearly all of our staff are vaccinated first time, but they've not had the second doses yet, they will be getting it. So if the monitoring is required, with the principles of decreasing or the risk of worsening, and then if the recovery at home can be facilitated earlier with some enablement and rehabilitation and equipment, and then if any investigations needed to just review the progress is the only time we go in for monitoring. So they will be usually a short period of time which we intervene, usually 5 to 6 days, and then most of them will be discharged back. If they will be back to independence or help with the community, or if they need long-term planning or caring, then we will send them back to the frailty assessment or social prescribers. These are all which have started to work much, much more clearly because of COVID, but I don't know how we should be using it in the future. We keep it simple, and that's what we can look at, that the patient is getting the best out of that. In your case, how would you consider in A&E, Ben, for patients to come out for us? Because there must be the same principles.
Yes, and what you're describing to me really is first of all, news score wise, are they sick? Are they physiologically unwell? Too unwell to be at home is the first question. Then clearly they're likely to need to come in hospital. The second thing is, if they're not physiologically, there are two more things. If they're not physiologically unwell, is there a thing where there is significant risk of deterioration? So someone might be physiologically stable but just had an MI. Clearly they're not. They may be very stable but clearly need admission to hospital. So in that situation, you could have a news score of 0 but have just had an MI. Clearly you need a non-STEMI admission, so you would admit them. Or the third one is actually they may not be physiologically ill. They may not be at serious risk of deterioration, but they may not be able to cope with their ADL. So if they can't climb the stairs because they're too breathless, even though they might not need oxygen, then it may be that in their situation. But you've got to look at alternatives. So in daytime hours for that group of patients, you look, okay, can we put them into a respite bed? Can they go into somewhat a community hospital bed? Do they need to be in an acute hospital bed? And the key thing, other thing in that is, what's the risk of admission as well? And we're very good in looking at, if they go home, this might happen. We're not very good sometimes in healthcare looking at if they're admitted to hospital, there's a risk of deconditioning, there's a risk of DVPE, there's a remote to immobility, there's a risk of nosocomial infection, COVID, but before COVID, there's plenty of other things. And we know that particularly the frail elderly will lose independence as well. And therefore lose confidence and therefore harder to discharge. So actually, you've got to look at, yes, there's a risk of going home, but there's also a risk of admission. And actually, where does that sit? And what we I try to do, what we talk to our team about, is talking to the patient, or there's actually a risk of admission here. Actually, so getting you home at right now, you are sick, but you're not sick enough to need hospital treatment. So can we get you at home? Can the relatives help? We've got a community team in the front door who we can call on who will try and help people get home, bridge care package gaps, that sort of thing. Changes on the time of day. So at 4 in the morning, it's very hard to put an alternative in place, and sometimes you admit them for a very short period of time because in the morning you want a therapy team, a fit frailty team to assess them first thing, but admit them with a position they're going to go home. And actually, the other group is probably the sort of the care home patient group. They've already got a set of nursing staff with them, so you don't need to admit people who've fallen and banged their heads for neuroobs, because the care home staff can do that. So don't admit them for things. Always think about what is the situation for the patient. And the other group is the very frail elderly in care homes. If we admit them because their troponins mildly raised, are we going to do an angio? No. Are we going to do this? No. So is it actually going to change their management in the long run? And ask the patient what they want. If the patient can't answer because they're confused or demented, often ask the family, not what they want, but ask the family, if the patient could rewind 10 years, could see themselves in their bed right now, would they want to go into hospital and have X, Y, and Z done, or would they go back to their care home and go, actually, do you know what? I'll go with the oral antibiotics and see what happens. And that's often a very powerful way of talking to relatives about, we can treat stuff in hospital. Not everyone needs to be treated in hospital. It may not be in their interest to do that. So for the very frail elderly towards the end of their life, it's really important to look at, because everyone we do admit who doesn't need admission puts them at risk of all those things we've discussed. But actually, if we admit someone who doesn't need admission, we put other people at risk as well. We know to make beds, people will be outlied. We know outliers have a higher length of stay, have a higher mortality. Or they take a bed up and someone else in ED who's really sick, a stroke or neck of fever, who needs a bed, may sit in the emergency department for 10, 12 hours sometimes. And that's detrimental. We know that's got a higher mortality. Or even worse, someone sits in the community waiting for an ambulance. So it's that knock-on effect of unnecessary admissions that not just put that patient at risk, but others as well. And it will vary from time of day. And I think the key thing would be getting people home as soon as we can. They don't need, if they are admitted, they don't need to be better to go home. They just need to be well enough to go home. And probably the most powerful question you can ask on a ward every given day is, if I saw them in ED or the community right now, as they are today, would I admit them? If I wouldn't admit them, I probably should be discharging them. And that's the other way of looking at it. It's just a different reference frame because every day we keep them in, we keep them at an increased risk, and we need to talk about that risk of staying into the patient as well. How do you deal with stuff when people are being discharged from hospital? How do you deal with the risk of that? And how do you decide when you take people back out, step down patients? How do you look at that in the community?
I mean, it's again keeping it simple. What is the need? Supposing you say that the patient's family does not exist with them, because majority of our patients are 80 plus, and average age in our service is 85.8. So it's quite, 89 years of age, which they're frail. They needed some help. They've been in a short period of time, a longer period of time, which means they've deconditioned. Even though they might be in a couple of days, or they've been unwell for a few days at home, they come to you. We still, again, keep the same principles. Are they able to look after themselves with activities of daily living? We keep it simple again, washing, dressing, eating, and able to take the medications. If they need support with that, it's very simple. We put in our teams, it could be an enablement team. We still send the nurses in to ensure, because the condition when they go home, especially now with the discharge to assess process in pathway 1, there are patients who go home and then sometimes deteriorate, but that's not because it was a poor assessment. These are elderly, frail patients. Things happen to them. The risk at that time might be different. They might refuse to go in. I mean, the biggest risk is falls, as you know. So we try to look at every single risk available, but then you can't really tick every box. The risk also, again, insists for us is what can we do? Like checking postural hypertension, orthostatic blood pressure in every visit, making sure a frail patient on polypharmacy does not get low blood pressure when he stands up, and that risks of fall. Looking at polypharmacy, fluid intake, making sure that they get the same things as increased fluid intake. And then following that one, the therapy assessment for any equipment needed or low-level assessment. And then we ensure that if they can manage, usually they do recover quite well at home. There is a 30% increased activity level at home, even though they're in the hospital. So we use those principles of seeing how do we ensure that they can get back to, and something happens at home. They feel happy, the quality of life's improved, and also they seem to listen. The risk is that we need to take their risk. Sometimes we tell them you need to go in. They've got their inflammatory markers of CRP in the hundreds and white cell count high, but they said, I'm walking to the toilet. We said, look, if you looking at the numbers, you're poorly, we tried antibiotics, but we don't know what else is going on. They said, no, we'll wait, I'll stay at home. But we have informed them of the risk, and they will say, we'll call 999 or some. And I think that conversation of saying that we have done this bit, you look a bit unwell, more than what is supposed to be according to the current condition, but we can't put our finger on it because in other words, we say that in a septic situation, but you're not septic because you're walking around, but we can't help you because we're not there 24 hours. Do you want to go in? And sometimes they say, no, we got to accept that risk. These are frail patients who know themselves. And I think that was one thing we learned in COVID is they have taken risks and they've accepted it. Who are we to question them if they have the capacity? A capacity assessment is compulsory on all these patients. Even though they're hypoxic, if they don't have the capacity, then we really need to take into consideration, are they really taking the right decision?
Yeah, so what you're saying, I think, and I agree with you, is the risk belongs to the patient, and our job is to talk about all the risks, risks of admission, risks of discharge, and then allow them to make their, just like you would for elective care and operation, but that the same rules apply in emergency care. And I personally very much strongly feel that there is no risk scenario, and this thing of you can't avoid falls. In hospitals, we try to avoid falls, for example. You can't avoid falls, and there's a risk of falling. So because someone might fall doesn't mean they shouldn't go home, because someone might. And the concept I asked you about was failed discharge. The concept of, well, we keep them in case they come back, and the failed discharge, which is a really poor thing to say about a patient. What do you think about that in terms of there is a risk of someone may come back in, but that's not always a bad thing?
No, the risks is usually in the first 24 hours or 48 hours. Nearly 50% of readmissions happen at that time. So there are quite a few things. Age UK, give them a call. Some GP practices give them a call as well. The ones which are in pathway 0 are the ones which do not. But the ones which come through with us seem to benefit from review because there is a senior review, or if there is an healthcare social care team review. But it's from 48 hours to 7 days, and that's when the majority of the other readmissions happen. If you look at it, it's usually due to polypharmacy, around about 16%. If they go home without themselves, I think they've got to sometimes, what we have seen more often is that some of the medications are stopped in the 2 or 3 day admissions. When they go home, they've got their own set of medications as well. They don't know what to do. So that also increases their risk. That's not because they don't know what to do, but it's purely because it's confusion. The transition of care is an issue. And then the 7 to 14 days when we calculate, those are new events. So you're looking at nationally, internationally, most of the data shows 16% is an amazing number to keep it at, but looking at national, 35 to 50% is the current statistics in England. We look at around about 11% locally because when they come to us and when they put in things like Age UK, those are the things which we need to be helping those patients at transition of care. I know 2 days is not transition of care, but for the patient is a massive transition of care because living in a 24/7 setting and then coming home to not being alone again with the TV as their only company, it makes a big difference.
Yeah, cool. So I think what you're saying is really the It's about good communication between the hospital and the community teams, and it's about safety netting patients, and it's about letting the patients take that risk and understanding that um, that it's better to get someone out quicker often, where they can be independent, where they can move around, they can gain their independence, than keep them in case they come back. And it's about balancing that risk off of the two things and talking to the patients. And that's my approach in the front door as well. Is what's the right thing for them? How do we balance that risk, or have we talked to them? And what can we do if we are going to send them home? How do we safety net them? Um,
I think we often get patients' family right now because of COVID on the phone calling us up and saying, oh, if they fall, we're not going to be too happy about it. We just give them the simple answers that we can't stop them from falling. What we can do is we have looked at all the risks, we have tried to eliminate all the risks, but I can't stop your dad or mum or grandma and granddad to do what they want whenever they want because they have capacity. But they've been told that between the visits, you need to have some help. Can you use the Zimmer frame because of their condition? If not, if they have capacity to do furniture walking, that's fine. But that still does not, we can't be 100% risk averse because these are independent people living in
yeah,
England and they have got every right to do what they want. But for us as healthcare professionals, we can only look at eliminating the identified risks, finding out anything which we don't know about, and then trying to put things into place, and then letting the patient decide what's best for them, and we help them with what is necessary. Frail patients do not have long. I mean, when you look at the e-frailty index, or if you look at the last 1,000 days of life, the longer they stay at home, the quality of life is better. They're much happier. There's less
yeah.
iatrogenic stuff which happens. And I think we need to keep that into perspective of seeing how we can help them their last 1,000 days of. I mean, if they already past the average age in England for men, which is 85, and 88 as women. So you're looking at patients average age of 89, 88 in the community right now from community teams. So I think the risk will always be part of anything we do, but understanding that the patient takes the risk and we help them to minimize it and also help them to embrace it is what we should be doing.
Perfect. Thank you very much.
Thank you, Ben. Thanks for your time.